Hello, welcome to the second online lecture for Module 4. This is a follow-up to the first posted online lecture on models of care and evidence-based practice, so make sure that you've watched the first Module 4 lecture before watching this one. In order to be successful for this lecture, it will have helped if you've read the article that was posted on Blackboard, that you have read and understand the criteria in the Pedro scale, and then are able to apply the criteria to, or at least some of them, to this article, and then decide whether or not the study's results are important enough that maybe a clinician should change their practice, or, as a researcher, would you consider the results of this study as being conclusive? So a brief recap from our earlier discussions that most, if not all, health professions have adopted the principles of evidence-based practice. PEDRO, which stands for Physiotherapy Evidence Database, is a scale developed by physiotherapists in Australia, and it's used to evaluate the internal validity of RCTs, or randomized control trials. The Journal of the American Medical Association has also created articles on how to evaluate articles, and the Pedro scale follows these articles very closely, but it's really less intense on the statistical requirements, and it's also easier to follow. So the Pedro scale then is not specific to physiotherapy, only created by physiotherapists. What is a systematic review? The correct answer to this question is E, all of the above. A systematic review is a type of literature review that collects and critically analyzes multiple research studies or papers. It's really a review of existing studies. Systematic reviews of randomized control trials are key in the practice of evidence-based medicine. This you'll also recognize from the online lecture where we discussed the original chronic care model. Recall from that lecture that Ontario, among other jurisdictions, was having problems with respect to organizing healthcare for people with chronic diseases, or how we know them as non-communicable diseases. And the focus has always been on infectious diseases or communicable diseases. So in an attempt to address the problems that the healthcare system has and seems to continue to have in regards to really addressing chronic diseases in a comprehensive way, a healthcare organization from Seattle, Washington created the chronic care model. So what is the purpose? Well, it's to help guide health services and how they should be provided to those with chronic diseases. Now, although it was successfully implemented, there were a few problems with it, as we've already discussed. First of all, there was not enough emphasis on two important factors. Those important factors involved prevention and health promotion. And health promotion can be defined as the process of enabling people to increase control over and to improve their health. An additional problem was that this model presented a very narrow perspective on the role played by community supports. And third, there's less evidence available that suggests that this model is applicable for complex chronic diseases. And a key word there is complex. So what was done about these criticisms? Well, enter the expanded chronic care model. This model addresses some of the problems with the chronic care model as discussed on the previous slide, and it adapts it to more of a Canadian context. It emphasizes things such as prevention and health promotion, which we said were lacking in the previous model. The emphasis is not just on reducing the impact on those who have the disease, but also on supporting people as well as communities to remain healthy. For a detailed explanation on both models, you can revisit it in the online lecture, but the required readings will also assist. Now, before we start looking at the Pedro scale criterion and the assigned article, I want you to remember that one of the criticisms of the original chronic care model was that there's less evidence that it's applicable to complex chronic diseases. On this slide, I'm introducing the guided care model, or reintroducing, which is an extension, really an adapted form of the original chronic care model, and it addresses the issues of complex chronic conditions. It was created by researchers at Johns Hopkins University, and in this model, primary care nurses are specifically trained to care for about 50 to 60 older adults that have chronic conditions, as well as having complex healthcare needs. You can see a list on the slide of the different roles that the guided care nurses were responsible for performing. So there's quite a list here. 8 clinical activities. There's evidence from randomized control trials that when applying this model to older individuals that have complex chronic conditions, this approach will lead to such events as improved health outcomes. It will reduce overall costs. It's going to lower burden on families and communities, and it leads to a greater level of satisfaction among the health professional, which is also a very important consideration. As posted on Blackboard, hopefully you read the article called Early Effects of Guided Care on the Quality of Healthcare for Multimorbid Older Persons, a Cluster Randomized Control Trial. And then my hope is that you've tried to apply it to the Pedro scale criteria. First, let's break down the title. Guided care is the model that I discussed on the last slide, which is a modified, adapted, or really updated version of the chronic care model. This study is looking at multimorbid older persons or older persons with complex chronic diseases, and it was done as a cluster randomized control trial. A randomized control trial is, to refresh your memory, is a study in which people are allocated randomly, so by chance alone, to receive one of several clinical interventions. One of these interventions is the standard of comparison, or the control. And so the control could be standard practice, such as maybe a standard practice such as a placebo or a sugar pill, or it could be no intervention at all. Now, a cluster randomized control trial. This is a type of randomized control trial in which groups of subjects, as opposed to individual subjects, are randomized. Although we'll use the term cluster randomized control trials, sometimes you'll see it written as cluster randomized trials, group randomized trials, or place randomized trials. Now, a double-blind study. Remember, this is one in which neither the participants nor the experimenters know who is receiving the particular treatment. This procedure is utilized to prevent bias in research results. The following slides are going to be covering the Pedro criteria and applying them specifically to the content of this article. And hopefully by the end of it, you'll be able to develop an opinion as to whether or not this paper meets the criterion and makes it internally valid. Criterion number 1 on the Pedro scale. This is the first one, of course, and it asks the question, did the researchers specify the eligibility criteria? This criterion is satisfied if the report describes the source of subjects and a list of criteria used to determine who was eligible to participate in the study. That is, what variables allow someone to be included in the study, so the inclusion criteria, and what variables would exclude someone from the study, so the exclusion criteria. So then the question I would ask you is, what is validity? And I'm sure you could come up with a variety of different good answers for this question, but in general, validity is an indication of how sound your research is. More specifically though, validity applies to both the design and the methods of your research or someone's research. Validity in data collection means that your findings truly represent the phenomenon you are claiming to measure. Valid claims are solid claims. So now that we have determined what validity is, what is the difference between internal validity and external validity? Well, again, speaking very basically, and this comes from your readings, external validity is the extent to which the results of a study can be generalized to other situations and to other people, whereas internal validity refers to how well an experiment was done, especially whether or not the study avoids what are considered to be confounding variables that can impact the study. A confounding variable is a third variable. These are variables that the researcher failed to control for, maybe they failed to eliminate for, and this can damage the internal validity of an experiment. So now that you know the difference between external and internal validity, the next question is, does the inclusion of criterion 1 of the Pedro scale influence external validity or internal validity of the trial? Or do you think it's both? Well, this criterion influences external validity, not internal validity of the trial. So it tells us the extent to which the results of the study can be generalized then to other situations and other people, rather than telling us how well the study was done. So, if you recall from an earlier slide, I told you that the Pedro scale, and when I say scale, I'm referring to the points on the scale, that it's used to evaluate the internal validity of RCTs. And since this criterion evaluates external validity, it is not used to calculate the Pedro score. So why do we have it? Well, on an earlier slide and also in the readings, you may recall that the Pedro scale is based on another scale called the Delphi list. We include criterion 1 in the Pedro scale because it is also included in the Delphi list, but we don't use it as part of the Pedro score, and that comes down to the difference between external and internal validity. So criterion 1 with respect to this study, were the eligibility criteria specified? The answer is technically yes, but it was very complex in this particular study. For this criteria, we know that we need to know the source of the subjects and list of eligibility criteria. Why is this criteria tricky for this study? Well, there was a lot involved. There were 2 different subjects. We had patients and primary care providers. So first of all, individual primary care providers were eligible if they worked 70% of the time at these practices. Now, a practice itself was eligible if A, they cared for at least 400 patients who were 65 and older, and B, they had space for guided care nurses. The second group of subjects had to do with the participants themselves. So recruitment of patient participants was multi-staged. So there's a long list of inclusion and exclusion criteria for subjects themselves. For example, in the study, they reported that inclusion criteria included that they had to be patients of participating physicians, they had to be 65 years or older, they had to be covered by fee-for-service Medicare, Parts A and B, Kaiser Permanente Medicare Advantage, or TRICARE, and you don't need to know the details of that for testing purposes, but this comes right from the article. And they had to be high risk for heavily using healthcare services, and this was determined by an Applied Hierarchical Condition Category, or HCC. Exclusion criteria included not having a telephone, not being able to speak English, if they were planning on any extended travel, and if they failed a cognitive test. So once again, answer to this question is technically yes, but it was much more complex than a lot of other studies you might read. The second Pedro scale criterion deals with random allocations to groups, and it requires the report to state that random allocation was used. Well, what's the big deal about random allocation? And this I mentioned as well in class. If sample size is large enough, random allocation assures that both known and unknown determinants of outcome are evenly distributed between the treatment and the control groups, really making the groups comparable. So for example, you could have a medication group, which is the intervention group, and the no treatment or placebo group. You want to keep the groups comparable by distributing the known and unknown determinants of outcome. Once again, it's not necessary to specifically state the method of randomization. In other words, if they used a coin toss or computer-generated number to randomly allocate these individuals, then that is suitable, but they don't need to state it. So were the subjects randomly allocated to groups in this study? Well, yes, they were, but not in the usual way. So what was different about this randomization procedure? Well, the unit of randomization was called the pod, and there were 14 pods rather than being called participants. The pods included the primary care provider and the patients. As you would recall, this is a cluster RCT rather than an individual RCT, and so groups of people, rather than individuals, are randomly allocated to undergo the interventions under investigation. So why do this? That is, why have a cluster RCT versus an individualized? Well, advantages of cluster RCTs over individualized RCTs is that sometimes you cannot study an intervention directed only at an individual, and so a group makes more sense. Can you think of any other instances where a cluster RCT might be useful? Well, some other examples might include in a general practice, in hospitals, communities, schools, or even amongst families. Criterion 3 states that a study needs to state somewhere that the person who determined study eligibility criteria is not the same person that allocated subjects to the intervention or the control groups. Otherwise, this could create what's referred to as systematic biases. Now, this does not need to be stated explicitly, but it could say, for example, that a sealed opaque envelope was used to allocate patients to the intervention or the control group. Allocation, as mentioned in class, can have an impact on effect size. Effect size is a simple way of quantifying the difference between two groups. It really emphasizes the size of the difference. Now, in terms of proper concealed allocation, one study showed that trials with inadequate allocation concealment can exaggerate the estimate of the effect size of interventions by as much as 40% on average. The irony here is that allocation concealment is such a simple maneuver. It can be incorporated in the design of any trial, and can, as I said, easily be implemented. So was allocation to groups concealed? The answer here is unclear or unsure. And I'm going to give you a quote from the article. 14 pods comprising 49 physicians and 904 consented patients were assigned by a random allocation program operated by the study statistician to either guided care or usual care for 2 years. So, not very clear. Now, what type of bias would proper concealment prevent? It can prevent what's called selection bias. Selection bias is the selection of individuals, groups, or data for analysis in such a way that proper randomization is not achieved, thereby ensuring that the sample obtained is not representative of the population intended to be analyzed. It's sometimes referred to as selection effect. If we do not know whether or not allocation to groups was concealed, then we may have the issue of selection bias. So this concept goes back to the last slide discussing effect size exaggeration. The fourth criterion requires that the researchers ensured that the intervention and control groups were similar at baseline on important factors. One important factor should measure condition severity, and another should be a measure of one key outcome. Key outcomes are those outcomes which provide the primary measure of the effectiveness or lack of effectiveness of the therapy. So why bother doing this? Well, discrepancies between groups may be indicative of inadequate randomization procedures. This will assist with reassurance about the study's validity. So were the trial groups similar at baseline regarding important prognostic factors? The answer here is no. Where would you look for this information? Table 1 on page 325. It includes a measure of severity at baseline, so for example, self-rated health. It includes key outcomes at baseline, so we can consider the patient assessment of chronic illness care as the main outcome. Now, is there a difference between usual care versus guided care groups at baseline? There seems to be. And this could possibly be due to there not being enough pods to randomize. So this means that any difference you find at the very end might not be due to the effect of the intervention, but because the intervention group was doing better to begin with. So did the researchers try to adjust for these differences at baseline? They did. You can read about the Patient Assessment of Chronic Illness Care, or PACIC, within the article. Criterion 5, 6, and 7 all deal with blinding for different people that are involved in the study. Criterion 5 requires that the participant is blinded to the treatment groups, meaning that the participant cannot or should not be able to distinguish between the treatments applied to the different arms of the trial. In other words, they shouldn't know if they're getting the actual medication, for example, or the placebo. Remember the Hawthorne effect. We talked about this being an experimental artifact in which subjects' responses are distorted by how they expect the experimenters want them to respond. So if a subject thinks they're getting some sort of new treatment or new medication, then they may report being better than they really are. So being unaware of what arm of the trial they're a part of assists greatly with this in terms of study validity. Otherwise, if a subject's not blinded, then there is risks to the validity of the study. I want you to make note of the fact that allocation concealment is completely different from blinding. The former seeks to eliminate selection bias during the process of recruitment and randomization, whereas the latter seeks to reduce performance and ascertainment bias after randomization occurs. So were the subjects blinded to the treatment groups? No. The subjects, or the patients, were able to distinguish between the treatments applied to the two groups, and there was no mention of attempt to blind or make the guided care versus usual care groups seem like they both could be under investigation. Criterion 6 requires that the researchers themselves blinded the therapists who administered the therapy. Blinding of therapists involves ensuring that therapists were unable to discriminate whether individual subjects had or had not received the treatment. When therapists have been blinded, the reader can be satisfied that the apparent effect or lack of effect of treatment was not due to, let's say, the therapist's enthusiasm or their lack of enthusiasm for the treatment or the control conditions. If one treatment is thought to be less effective, those given it might receive more care and maybe more attention to compensate for the anticipated deficiencies. So then, was there blinding of the healthcare providers who provided the interventions? And the answer to this question is no. There was no indication of attempt to blind the guided care nurses or physicians from being able to discriminate between subjects who had or had not received the treatment. In fact, the guided care nurses were specifically trained and knew very well who got the guided care intervention. Criterion 7 requires blinding of the assessors who measured at least one key outcome. Blinding of assessors involves ensuring that the assessors were unable to discriminate whether individual subjects had or had not received the treatment. There is mention of masking assessors. This would usually mean that the criteria would be met if you see this. When assessors in this case have been blinded, the reader can be satisfied that the apparent effect or lack of effect of treatment was not due to the assessor's biases impinging on their measures of outcome. The Pedro scale further stipulates that if the key outcome is self-reported, so for example with use of a pain diary, then the assessor can be considered blind if the subject is blind as well. If the assessor knows allocation, they may subconsciously record a better outcome or encourage patients more to achieve a better outcome if they believed that the new treatment was in fact better. So was there blinding of assessors? No. The assessors were not blinded. Criterion 8 requires that a large majority of the study participants stay in the study from beginning to end. If more than 15% of participants are considered to be lost to follow up, then the validity of the study is threatened. The concern is that patients that are lost to follow up are different from those who will actually end up remaining in the study. In other words, they have a different prognosis, which introduces a bias. Some people may drop out if they suffer adverse outcomes. Maybe they're doing better, so they don't think they need the therapy any longer. Criterion 9 requires that the researchers of an RCT use an intent to treat analysis. So what is an intent to treat analysis? Intention to treat analysis means that the analysis compares patients in the groups to which they were originally assigned, regardless of treatment actually received or whether there was deviation from the protocol. So why is intention to treat important? One, it will preserve value of randomization, which was done to equally distribute prognostic variables so that the effect will be due to the assigned treatment. Two, it gives a pragmatic estimate of the benefit rather than the potential benefit in patients who receive treatment exactly as planned. When I say pragmatic, I mean dealing with things that are sensible, realistic, in a way that is more practical rather than theoretical. Criterion 10 stipulates the need for researchers to include an appropriate statistical test to compare the groups. You don't need to spend too much time on this item, as I've mentioned before. Simply identify if some statistical test was done or not. Because you need a formal method to compare the two groups. So you'll see things such as t-test, ANOVA, RR, with p-values or confidence intervals. In clinical trials, statistical tests are performed to determine if the difference between groups is greater than can plausibly be attributed to chance. Finally, Criterion 11 requires that the study investigators included a point measure and an appropriate measure of variability. And listed here are different examples of point measures, which is really an indication of the size of treatment effect. And these are important values to report in order to further allow for internal validity of a study. So what do you think about this study? It was a little bit more complicated than other studies and in some ways more difficult to apply to the Pedro scale. But if you were an administrator at the Central East Local Health Integration Network, would you suggest to the board members to act on the results of this study? Why or why not? And you don't have to justify it right now, but it's something certainly to think about. That's the end of today's lecture. Thank you for